Welcome, everyone. Thank you so much for joining us for this virtual UMiami Health Talk. Let's talk about heart health and hypertension. This is to kick off this February Heart Month. I'm Iliana Bravo, your moderator for this evening's UMiami Health Talk, which is presented by the University of Miami Health System Cardiovascular Department. UHealth's cardiovascular experts pioneer and advance the latest diagnostic, minimally invasive, and surgical procedures. UHealth is home to the only American Heart Association certified hypertension center with access to latest breakthroughs in research, effective treatments, and personalized care. As an academic-based cardiac and vascular program, they offer patients a multi-specialty care approach by a recognized team of experts, as well as specialized programs for heart disease prevention, hypertension, arrhythmias, heart failure, and more. We ask you to learn more about UHealth's cardiovascular department by visiting umiamihealth.org/cardiovascular. And to schedule a consultation and screening, call 305-243-5554. We're going to repeat that information at the end again, so don't worry, we're going to have it for you. So tonight we're going to hear from our cardiovascular experts, Dr. Chatzizisis and Dr. Hurtado Rendón. We're also going to have a Q&A session, which is a great opportunity for you to ask direct questions of our experts. Just use the Q&A feature at the bottom of your Zoom screen. Take a look at your computer, device you're on, and that's where you're going to enter your questions, and we're going to prepare them for our experts. So let's kick things off with our first speaker, Dr. Yiannis Chatzizisis, Professor of Medicine and Chief of the Division of Cardiovascular Medicine at the University of Miami Miller School of Medicine, an internationally recognized board-certified interventional and imaging cardiologist. Dr. Chatzizisis has received more than 40 international and national awards. Help me welcome Dr. Chatzizisis. It's yours.
Thank you so much, Iliana. We are, along with Dr. Hurtado tonight, so thrilled to be together for one more time in this online virtual gathering to discuss with our community and educate our community on the latest on the role of imaging in cardiovascular prevention and with emphasis on hypertension, the latest in its management. I'm going to start with, first of all, addressing the strengths of our ecosystem where the cardiovascular program at the University of Miami operates. We are very fortunate to have a very visionary leadership at both the UHealth and the Miller School of Medicine level. We collaborate with partner with very skillful faculty and staff, and this makes a difference in our services to our community. We have world-class research centers and institutes. We have extensive clinical and research infrastructure. And of course, we operate, all of us, under the umbrella of the premier academic ecosystem of the University of Miami. And we're here to serve the community. And our mentality is the experts should be at the neighborhood to serve the community through this big line of smaller or bigger multi-specialty medical centers. We serve our community in Miami-Dade, in Monroe County, in Broward County, all the way up to Palm Beach. And of course, we have the motherland here, the main tower, where we have the ability to perform advanced diagnostic and therapeutic procedures. What is our mission in the cardiovascular program? To offer the finest clinical care, to bring world-class research and innovation, to educate and train our trainees with the latest, integrate digital technologies now that AI is so popular, and of course, collaborate with academia and industry. Speaking about clinical care, very important to realize that we don't just see patients or do procedures, but we do see patients and do procedures in the context of programs where we have emphasis on quality and outcomes, which is for us non-negotiable, and innovation. We bring the latest technologies, software, hardware in this community to offer the best care. And that's how we bring reputation, and we operate like that all the way from prevention to diagnosis and therapy of cardiovascular disease. Speaking of clinical programs, as you can see, we offer programs which span all the way from prevention, nutrition, management of hyperlipidemia, hypertension, as you can hear more about that tonight, women's health, management of coronary artery disease from prevention to diagnosis and advanced therapies, valvular and structural heart disease, including both percutaneous and minimally invasive surgical approaches, aortic and peripheral disease, electrophysiology, including AFib, advanced therapies for ventricular and difficult arrhythmias, and of course, heart failure, all the way up to mechanical support and transplantation. But tonight, the focus is more on the preventive cardiology and on cardiovascular imaging. Dr. Hurtado will take the stage after me on hypertension. I'm going to focus more on the role of imaging. We truly believe that every man older than 40 and every woman older than 50 warrants a kind of checkup in a preventive cardiology program to identify the risk for future events, cardiovascular events, and tailor this accordingly. And I'm going to focus more tonight on the role of imaging in cardiovascular prevention. And what is imaging? It's cardiac CT, it's cardiac MRI, it's cardiac PET, nuclear cardiology, as we call it, and of course, echocardiography. And all these four modalities are offered with a wide variety of services in our programs. And we have to appreciate the fact that the field has evolved in cardiovascular imaging and assessment, from the stethoscope back in 30s to the echo in 2000s, and nowadays to the role of CT, which plays important role in diagnosis and prevention with calcium score and plaque analysis. And I'm going to focus on both these entities tonight. Through CT, we can have calcium score assessment and plaque analysis. Starting with the calcium score. What is calcium score? It's a very quick test, 2-3 minutes, no IV, no contrast, very low radiation. Patient goes through the scanner, and then this gives us a picture of how much calcium we have in our heart arteries. And why this simple test and safe test is so important? Because based on the calcium score, which can vary all the way from 0, which is normal, all the way up to thousands, we can now define the individual patient's risk to have a stroke or heart attack in the years to come. And it can be very low when the calcium score is 0, or low when it's below 100, all the way up to moderate and high when it exceeds 300. And why this is important? Because when the score is low or very low, we don't need to be on aspirin. And our LDL goal, the bad cholesterol goal, should be below 100. And we can achieve this with a statin, if we have risk factors, or even with lifestyle changes. But when the calcium score starts creeping up more than 100, even more so, more than 300, then we increase our risk. In that case, we need to take aspirin, and we need to be more aggressive with our LDL goal through several types of pharmacotherapy and several variations of intensity of this pharmacotherapy, all the way up to multiple agents with statin and ezetimibe and PCSK9 inhibitors, the injectable doses as we have nowadays, which help us to minimize the risk by dropping the LDL, the bad cholesterol, as low as possible. And now we are at the stage that things have evolved even beyond the calcium score. We have noticed that having a calcium score of 0 is good, but not enough, because up to one third, up to 30% of cardiovascular events, of strokes and heart attacks, happen in those who have 0 calcium score, despite being on lipid therapy, lipid-lowering therapy. And why is that? As you can see in this study, a wonderful study in 4,000 plus patients a few years ago, we randomized patients, 2,000 patients, on having a coronary CT angiography and the other half on just standard of care. And we found that with CT imaging, we can reduce the risk for heart attack and death over 5 years by up to 41%. So it's of immense importance to be able to see in the heart arteries what's going on before something bad happens. And why is that? Because as you can see here, we now have these beautiful technologies that give us the mapping of the whole, it's like the genotyping of your heart arteries. It's the whole mapping of the lipids plaque, the soft yellow plaque, the blue plaque, which is calcified plaque, all the way across the heart arteries. And knowing the total plaque volume, we can predict the individual risk for a heart attack or death in the future. And based on this risk, in a very individual basis, we can decide who takes what medication and what is the bad cholesterol goal, because this goal is tailored to your individual risk based on your total plaque volume. And I'll give you a very characteristic example here. This is a 50-year-old man with chest pain. This is his scan, his plaque mapping in July 23, when LDL was 130, quite high, not super high, but quite high, with plaque, yellow plaque, soft plaque, responsible for cardiovascular events, as you can see here. All this is plaque. And then 2 years later, with pharmacotherapy, with statins and so on, and when he managed to drop his LDL from 130 to 23, see what happened 2 years later. The plaque volume, as you can see here, dramatically decreased. So now the pharmacotherapy, the statins and the injectables and so on, not only help us to stabilize the plaque, but in some cases, like in this case, they help us to reverse the plaque. And obviously, with less plaque volume, the risk for future heart attacks and death is significantly reduced. So it's of immense importance to have in our preventive strategies the calcium score, the plaque volume, the plaque analysis through CT angiography. And that was my message tonight, that prevention is preferable to cure. Cardiac CT plays immense key role in cardiovascular prevention. Calcium score and plaque analysis help us to determine the individual risk for heart attack and death. And based on that risk, we can define the management, whether it is just lifestyle changes, as well as the type and intensity of pharmacotherapy, set our goals on individual basis to prevent future adverse events. We're very happy and very proud in the University of Miami to offer all these imaging technologies to our community for prevention. We operate at the neighborhoods of our patients. Not everybody has to come downtown, at Lenar, Doral, Solemia, and of course, downtown areas. And as I mentioned, we offer calcium score, plaque analysis, fast appointments, concierge for our community. Our referring physicians is our mentality, high quality imaging, and the best we can offer to our community for better patient care. We are here, our program, to offer top class quality and parallel patient care, education and training to our trainees and to our community. Frontline in research and innovation, of course, set the standards in terms of what and how cardiovascular medicine should be in 2026. With that, I would like to thank you for your attention. And as we move forward, I'm more than happy to answer to any questions.
Thank you, Dr. Chatzizisis, and they're going to have an opportunity to ask both of you as many questions as they'd like, because this is so fascinating information as to where we've come in the 21st century. So let's introduce our next speaker, Dr. Iliana Hurtado Rendón, a board-certified cardiovascular specialist with advanced training in interventional cardiology and peripheral endovascular interventions. She completed a peripheral endovascular fellowship at Yale University School of Medicine and has authored multiple peer-reviewed publications and book chapters, including contributions to the American College of Cardiology. Welcome, Dr. Hurtado Rendón.
Thank you so much. Thank you, Iliana. So thank you, everybody, for being here. Today, I got the task to talk about a very important topic, which is hypertension. So let's start talking about what is hypertension. So what is blood pressure? So the blood pressure is the pressure of the blood inside of your arteries. I want you to think as your blood pressure as the water flowing inside through the pipes, and that's the pressure. So how do we quantify high blood pressure? We quantify it with two numbers, the top and the bottom number. The top number, or also called systolic number, is the pressure of the vessels when the heart contracts. And the bottom number, or diastolic number, is the pressure when the heart relaxes. So the American Heart Association has a very clear definition of high blood pressure. The normal blood pressure is less than 120 systolic, less than 80 diastolic, elevated between 120 and 29, and hypertension is staged by stage 1 hypertension or stage 2. Stage 1 hypertension is the systolic blood pressure between 130 and 139, and stage 2 is above 140. So why are we talking about today about hypertension? It's very important because almost half of the US adults have high blood pressure. And unfortunately, only 1 in 4 have it under control. Also, hypertension is very important because it's one of the major preventable risk factors for heart disease and stroke. Now, hypertension is a global crisis. And like I already mentioned, the incidence of high blood pressure is very elevated, it's high. About 1/3 of adults globally around the world has high blood pressure. From around 40 to 50% of US adults have high blood pressure. And most importantly, from that 40%, only 20% of our patients are able to control their blood pressure. Okay? So again, 1 out of 4 patients is able to control the blood pressure. Despite of all these awareness campaigns and we're trying to spread the word, only around 50 to 40% receive treatment, and even in a smaller amount, they are able to control their blood pressure. So why high blood pressure matters? Why we stress about hypertension? First of all, because it can damage your heart, your brains, your kidneys, and many organs. And second of all, because which I consider high blood pressure or hypertension is a dangerous disease. Why? Because it's silent. It won't give you any symptoms, any warning symptoms. So for example, any of us, we're walking, we fall, we break a leg. What happened? What we do immediately after? We go to the doctor, we go to the emergency, we ask for medical care and ask, hey, I broke my leg, please fix me, help me to fix this. But with high blood pressure, there's many people walking in the streets with blood pressure of 180, 190, 200, and they don't have any symptoms. But you know where the symptoms start, when the symptoms present? When you're walking into the emergency room already with a heart attack or a stroke. And that's why I think that we consider that high blood pressure is very important, that it has to be discussed with the community. So the causes of death worldwide attributable to systolic blood pressure, to high blood pressure of 140s. I'm not talking about 200s, 180s. Only above 140s are mostly ischemic heart disease, which is, in other words, a heart attack, stroke that can be ischemic or hemorrhagic, other heart disease, and chronic kidney disease. So now that we have already established what is the definition of high blood pressure, the numbers, we need to diagnose it. We need to know if I have high blood pressure. So how do we do that? We have to check our blood pressure at home, not only once, but multiple times and during different days. We're going to talk about what is the technique of checking the blood pressure at home. That's your part as a patient when you're at home. Now, we can help you with that with a monitor in the clinic, in our clinics. High blood pressure is are very dynamic numbers. My blood pressure right now, talking to all of you, it's 1. When I'm going to jump into my car and sit into traffic to go home, it's going to be a different blood pressure. When I get home and I relax and I go to sleep, it's a different blood pressure. So the 24-hour monitor that we can prescribe to our patients will give us the trend of what the blood pressure is doing at home when you're doing your daily activities, what your blood pressure is doing when you wake up, when you're having breakfast, what your blood pressure is doing in the evening, what your blood pressure is doing when you're watching TV or when you're sleeping. So that's going to give us a lot of information for a better management, better understanding of what is the behavior of your high blood pressure at home. And of course, better assessment on the management of your high blood pressure. So let's talk about check your blood pressure at home. It's very important, that technique, for us to get an accurate number of your blood pressure. So first of all, check your blood pressure when you're comfortable in a quiet place. Second of all, put your feet flat on the floor. And one thing very important, your arm has to be supported at the heart level. Don't check your blood pressure with your arm hanging down and the machine down or higher than your heart. It has to be at the heart level, okay? Now let's talk about the interesting part, the treatment of the high blood pressure. The high blood pressure has 3 different important pillars. 1, the non-pharmacological interventions, which I think is very important when we're talking about what do you do in your daily activities that can influence your blood pressure. Second, the pharmacological intervention, which is the medications, of course, also very important. What medications are you taking? How are you taking your medications? And third of all, the device therapy for hypertension. When we talk about device therapies, when the first and second pillar, when the lifestyle and the medications, despite of doing everything right, do not work. And that's where we can help you also with the device therapy. So let's talk about the first pillar, lifestyle changes. So I recommend to my patients 4 different actions. They have to do 4 different actions at home. They have to eat, exercise, lose, and stop. Eat less salt, and eat less processed food. That will help you to manage your blood pressure. Exercise is very important. The American Heart Association recommend 5 days of exercise a week, at least for 20 minutes, or 4 days a week for at least 30 minutes. The third one is lose. What you're gonna lose? You're gonna lose weight. Weight also can influence on the hypertension. And stop. What are you gonna stop? Stop smoking and stop drinking alcohol. So remember, eat, exercise, lose, and stop. Those are the 4 important things that you have to do to improve your lifestyle and make all those changes that can help you with management of high blood pressure. The second pillar, the blood pressure medications. So the medications not only treat your blood pressure and you take your medications only to have very nice numbers on your blood pressure machine, but it also protects your heart, your brain, and your kidneys, depending on what family of medications are you taking, a different type of medications. But most importantly, take them every day as prescribed. So when I have patients in my clinic, and I said, so Mr. Smith, have you taken your medications? Are you taking your medications the right way? And he answers me, yes, doctor, I'm taking them every day. Okay, so what time do you take your medications today? I asked them. Well, I took them today at 6 in the morning. What about yesterday? Well, yesterday I went out and I woke up late, and so I took it at noon. That's very important because it's not only about taking your medications every day. It's important that you take your medications at the same time every day. So every single medication, different type of medications have different types of onset of action. So there's going to be, if you take your medications at different times every day, there's going to be a period of time that there's no medication in your body. So it's very important not only to be disciplined, but also be consistent with the day and time, the timing that you take your medications every day. Finally, we're going to talk about the third pillar, the device therapies. So what happens when you are exercising, you're complying with your diet, you don't smoke, you're doing everything, you're taking your medications in the right way, and despite of that, your blood pressure is not well controlled? We can help you with that. There's a new technology that's where we can offer a new procedure that's called renal artery denervation. So this procedure is indicated for patients, like I mentioned, that despite of doing everything right, they're not able to control their blood pressure, or they're on a lot of medications for blood pressure. Okay, so what is a renal artery denervation? What we do during that procedure, we do an ablation in the nerves that are circumferential, that are around the arteries of the kidneys. Why? Because those nerves connect with the nerves also with the brain, and they control the blood pressure. This procedure, an ablation, helps to take care of those nerves, and also it's going to help us to reduce your blood pressure. So before doing this procedure, we have to do some screening, some testing, where we order a CT or an MRI for what? First of all, to make sure that there's no contraindications, that you are a good candidate for having this procedure. What type of contraindications you're going to ask me? So for example, if you have some type of obstruction on the arteries of the kidneys, or you have some type of structural problems, like for example, aneurysms, that will be a contraindication for this procedure. And that's why we do this test, CT or an MRI, to see the anatomy of your vessels of your kidneys. But most importantly, for planning, we have 2 different platforms for doing this procedure. And depending on your anatomy, we can plan which platform we can use. So that will help us to, first of all, have a smooth procedure, fast procedure, and most importantly, a safe procedure. So one of the 2 platforms that we have here to help with the ablation is the record ultrasound, where we put through the artery of the kidney a little balloon that gives ultrasound waves that with temperature is going to take care of the nerves around the vessels of the artery. They will take care of the ablation. And the second platform that we have is the Simplicity catheter, where again we put a catheter in the arteries of the kidney, and with a spiral catheter in different points, we do ablation through the artery of the kidney. Both of those platforms, we have them here in University of Miami, and depends on what's the anatomy of the patient, we decide which one we're going to use. Let's talk about now the results of this renal ablation. It's very important to know that this procedure, the renal artery denervation, can help you to reduce at the 1 to 3 months 10 millimeters of mercury of your blood pressure. Okay, 10 millimeters of mercury between 1 to 3 months after having that procedure. But most importantly, the results are sustained. After the first month, it has been shown that the blood pressure can lower down up to 20 millimeters of mercury. And most importantly, the results are long-term. You're going to see the low blood pressure for a long time, up to 3 to 5 years so far, are what the studies are saying. Okay, so this is one of our patients. This is a left kidney of one of our patients. Here we have the catheter, and we are inside of the artery of the kidneys. The renal artery denervation, I want to clarify something. It's an outpatient procedure. It can take maybe 45 minutes, maybe an hour, and the patient comes usually in the morning and they are discharged in the afternoon. They go home the same day, sometimes even before noon, they can go home, okay? The results, like I said, it's a long-term results. You're gonna see the results for after 3 to 5 years, even more actually. Most important, we do a follow-up on our patients to titrate down these medications. For example, your blood pressure drops 20 millimeters of mercury, so you're going to be seen by our specialist in hypertension. It's going to remove some of your medications. You can go from 5 or 4 medications to control your blood pressure to 1 or 2. Sometimes some of them, they just stop all their medications after this procedure. I want to show you very quickly a video about what do we do here in the University of Miami regarding renal artery denervation.
Hypertension affects about 1/4 of the global population. So we offer them the so-called renal denervation. And in that therapy, essentially, we hope that we will be able to achieve better control of our blood pressure. The procedure takes about 45 minutes to an hour. It is something that involves essentially accessing the groin of the patient, going with a catheter into the kidney artery. Then we go there with a special catheter, and then we give some energy, and this energy burns essentially all the nerves around the kidney artery. Those nerves are very well involved in hypertension, and by burning those nerves, we're able essentially to drop the blood pressure by, on average, 10 units of mercury. And that's more than enough to help the patients control better the blood pressure, and sometimes also, as I said, go off 1 or 2 or even more medications.
I take my blood pressure multiple times a day. It is much lower than what it's been. I hope I could keep like that at least without medication.
We plan to expand this operation to address hypertension and to help our community have a better and longer life.
I want to finish this presentation with 3 important points, I think, for the community that I can share. So first of all, know your numbers. Be curious. Go home. Check your numbers. What's your systolic? What's your diastolic? Like I said, sometimes there's a lot of people that walk around with very high blood pressure without knowing it. So go home and check your numbers. Know your numbers. The second of all, take your medications. Be compliant. Be disciplined. That's very important for you and your heart health. And the third one, which I think is a very important one, ask questions. Get engaged with your heart health. When you go to your primary care doctor, when you go to the cardiologist, ask him, what else can I do to control my blood pressure? What other options do I have? And with that, I would like to finish my presentation.
Thank you, Dr. Hurtado Rendón. Perfect. Thank you for informative presentations, and our audience for being so inquisitive, because they've thrown a lot of questions at us. So feel free to continue to enter them in the Q&A box while we're having this discussion, because we have a good half hour. One of the things that strikes me always, Dr. Chatzizisis, is when people say, I started medication for controlling mild hypertension. Can I ever go off it? This is one of the biggest points that patients has. Is it a forever, the rest of my life medication?
The direct answer is, unfortunately, it's forever. Unless we're in the small 5% of population of cases that it's secondary hypertension, in which case we treat the secondary problem. Let's say it's a kidney problem, or it's a sleep apnea or thyroid problem or other things. You have to visit a specialist, unless it's that special small portion of patients with secondary hypertension, in which case we treat the primary problem, we fix the hypertension. In the majority, in the so-called primary hypertension, when the problem is in the genetics, in the diet, in the lifestyle and everything, unfortunately, the lifestyle should be in place, complemented with medical therapy. And if it's refractory, very difficult to treat it, consider the interventional therapies. We might modify some medications if we add the component of interventional therapy, as Dr. Hurtado said. We might get some patients off some medications or reduce some doses, but in principle, the medications are here to protect us and stay there for the entire life. It's very important to keep in mind that controlling hypertension below the goal of 130, the big pressure, the high pressure, and below 80, the low pressure, and ideally below 120 and below 80, we bring substantial risk reduction and prevention for future kidney problems, coronary disease, and strokes. And when this comes, unfortunately, with the side effects of medications, we have to either modify the medications or consider more advanced therapies like the interventional therapies. But unfortunately, the drugs should be continued.
Okay. Dr. Hurtado Rendon, you talked about the self-monitoring at home, which there's a gulf of information as to which cuffs to wear at home. I know when to do it, all of those tips that you gave us, but people might be doing them wrong. And this is something that I hear a lot from patients. Do I even know that I'm doing it correctly? When do I end up going to the doctor? Is it because of symptoms? Can you guide us a little on this?
Sure. So like I mentioned, the technique is very important. And we have different devices out in the public for selling. There's blood pressure cuffs that are on the wrist. There's other ones that are here on the arm. My recommendations are the one in the arm, like I said, at heart level. Okay. Second of all, you have to be relaxed in a quiet place, not chaotic, not running up and down. Just relax when you check your blood pressure. And the second of all, you have to have with your feet flat, not crossing your feet, because that can also alter the blood pressure levels. That's the most important, I think. Now, when to go to the doctor, you always have to have a primary care doctor. The answer is always go at least to your primary care doctors. And of course, if you have any heart conditions, go to the cardiologist. But your primary care doctor has to check your blood pressure. Yes.
Can I interrupt you for a quick second? Because then this question just came over. Are there symptoms associated with high blood pressure that I would recognize in myself?
So it depends on what stage, of what numbers. In many cases, patients, no, they do not have symptoms. They're walking around with 180, 200 of blood pressure. But when the symptoms present, they can be from chest pressure because of the heart strain, or of course, in just late cases, symptoms of stroke, which of course, you're gonna go to the emergency room for that. Yeah.
And now let me just stay on one more point on this of monitoring. I know we've come quite a while with AI devices, something called the BioBeats that they place on you to monitor you for 24 hours. Forget the old Holter monitors that were bulky and it looked like you were carrying a purse. Inform us on this so people are sort of key on where we are and how easy it is.
Absolutely. There for home monitoring, there's a lot of monitors. And like you mentioned, there's one with a blood pressure cuff on your arm that you wear it for 24 hours. So it can be very uncomfortable, especially because we want to see what your blood pressure is doing during your daily activities, and going around, going to work, going to grocery shopping with a BP cuff, it's uncomfortable. And not only that, but it's going to be pressuring your arm. For some patients, especially their age, and it can be difficult and it can be painful, and they don't want to do it. Now we have the BioBeat, which we have in our cardiology clinics, which is nothing but a sticker. Sorry to describe it like this, but it's a sticker that you put it on your chest, and that will give us, without any pressure or any BP cuff augmentation, will give us the trends of the blood pressure. It's going to give us the trends of the blood pressure in the morning, the afternoon, in the evening, so we know at what time and how much medication do you need. You know, what time it spikes, when it's not. So it's going to give us the trend of the whole blood pressure during 24 hours. The BioBeat is one of the newest ones, which we actually provide in the clinic, which you just put it like a little sticker on your chest and will give us that information.
I think that takes away a little bit of the fears and assuages patients.
Yeah.
Dr. Chatzizisis, you were talking about the medications before even intervention. We are also in a modern stage, not just statins. Now there are injectables, and there are very aggressive ways to get those kinds of numbers that you talked about, an LDL of 20 or 30, unheard of before.
The field has evolved, and we have realized that by dropping the LDL as low as possible, especially in the high-risk patients, those who have, for example, diabetes or who have suffered prior heart attacks and so on. So the lower has been proven to be the better. And there's no evidence, proven evidence, that low bad cholesterol, low LDL, is associated with cognitive impairment or diabetes and so on. At this point, the data is so strong in favor of big benefit by dropping the LDL and LPA, which is a new agent now, as low as possible, and not having any fear of any major side effects associated with low LDL.
Okay. I think this is for Dr. Hurtado Rendón. Are all patients candidates for denervation therapy, the one that you talked about so extensively? And who is this contraindicated for? Was there a good mix of patient demographics in the studies and outcomes?
Yeah. So that's a very good question, actually. I'm happy that you asked me that. So who is a good candidate? First of all, a patient. That's why we do a screening. We do an anatomical screening. First of all, we make sure that there's no secondary reasons why the patient has high blood pressure. Like, for example, adrenal tumors, obstructive sleep apnea, etc. No? So it's just essential hypertension. The second, when the patient is not able to control the blood pressure. Despite of that the patient is taking the medication, is being compliant, the blood pressure is still in the 140s, 150s, or even higher. So he's not able to reach the goal of the blood pressure. And then there's other type of screening that we do with imaging. And that's where the contraindications can come. When we do the imaging, when we do a CAT scan to see what is the anatomy of the patients, we want to first make sure the vessel size, the vessel length, that it's appropriate for this procedure. We're also checking on the tortuosity. Sometimes many vessels have very tortuous, a lot of bends. We want to also make sure that there's no obstructions in the arteries where we're going to work. And also, there's no structural abnormalities, like, for example, fibromuscular dysplasia or aneurysms inside of that vessel. Those will be mostly the contraindications where we will hold and don't do those procedures. But then the main thing, who is the candidate, is a patient who is not able to reach the goal that he wants with the blood pressure. He's not able to control the blood pressure, and there's no limitation of age. It can be young patients, it can be older patients. That's also very important to know. There's a lot of patients that we see on the clinic that are between 30s, 40 years old with very elevated blood pressure. So they also are very good candidates for this procedure.
Okay. Dr. Chatzizisis, let's talk about, you showed us those incredible images of the soft plaque and the hard plaque. What's the relationship to those types of plaques to the coronary calcium score? Is there?
Yeah, very, very good point. The soft plaque, the yellow plaque, as you saw, is what is the main reason for heart attacks and cardiovascular death. These are the soft, very unstable, very inflamed plaques that in the context of a stress, let's say you have a fight or emotional or physical stress, they can rupture and give you all of a sudden a heart attack. The blue plaques, as you saw in the pictures I showed, the so-called calcified plaques, are more cemented, more stable, and in a sense, somebody would expect to have more blue more cemented, more stable plaques than soft, inflamed, unstable plaques. And that's what the statins do. They take the yellow and convert it to blue. They increase the stability in the plaques, and this way they reduce significantly the risk for cardiovascular events, i.e., heart attack, death, and so on. Of course, the blue heart plaque comes also with a penalty, with a price, which is called chest pain, angina. You walk, you climb stairs, you have chest pain, shortness of breath, you have some discomfort, but this can be addressed through your cardiologist with a stress test, and if needed, with what we call revascularization, whether this can be a stent or a balloon, or sometimes in more extreme cases, a bypass. But that's more predictable, Iliana. If you would like me to pick what would be the worst, I would tell you to have a soft inflamed plaque, which at any moment can give you a heart attack, is the worst thing. It's better to have controlled, cemented, stable plaques, which give you chest pain, which is controlled and can be addressed. It's fixed with either stents or bypass. And of course, the ideal would be to have nothing.
Right. Let's talk about this simple calcium score test that you said, and it's really very simple, takes 10 minutes. If you have a 0, at what point should you repeat that test? Let's say you're completely asymptomatic. Do you do it at 5 years? I mean, I guess it depends on your age. It depends on other risk factors.
Correct. Correct. It's a low radiation test. That's very important, which means that at this point, the guidelines say we repeat our calcium score regardless of whether it's 0 or non-zero every 5 years. Of course, if it's very elevated, above 300, practically it's meaningless to repeat it. You expose yourself to unnecessary radiation. You're already high risk. Nothing more to know from repeated tests. But if it's below 300, we would like to repeat this every 5 years. And the reason is that this number is not just a random number, it's a number that gives us essentially information about our individual risk for future heart attacks and stroke. And the higher it gets, the higher the risk. And based on this risk, we can modify then our goal of LDL. For example, if my calcium score is 0, my LDL goal might be below 100. I can be a little more lenient to accept something above 100. Maybe not with a statin. But if my calcium score is 269 or 300 plus, in that case, I need to be more aggressive with my lifestyle and more aware of my future risk and more aggressive with my LDL. My LDL should drop below 50 ideally. And to achieve this, I need to be on a statin plus minus additional medications, including injectables. So totally different level of acuity and intensity in pharmacotherapy, depending on the number of calcium score.
Let's talk about something that people also get concerned about, age range. Are there adjustments on the values of blood pressure for patients that are, let's say, over 65? And does it relate to the hardness of the vessel wall because of age alone or irrelevant?
Dr. Hurtado, would you like to take this? The goal of LDL, of systolic blood pressure above the age of 65 and 70.
Yeah, sure. So, of course, the moment that you start aging, the vessels are going to get harder to say something. And so the blood pressure can go higher. Now, everything depends on the comorbidities and the other medical problems that the patient will have. The goal is the goal, 120/80. Hypertension, and that's why I presented the definition of the American Heart Association is above 130/80. Overall, especially except in specific cases and specific type of patients that they may have other different type of comorbidities, it's still 130 over blood pressure, 130/80. If it's higher than that, it's a hypertension and needs to be treated to decrease the risk of other problems like heart attacks and stroke.
Let's be gender specific. How about menopausal women? Calcium score even more relevant for them, or is the hardening of the vessels because of what happens, the loss of estrogen and all, also contribute, or not?
The menopausal stage.
A menopausal woman, yes.
Menopausal stage is a totally different picture physiologically for a woman. Everything changes in the body of a woman, including, of course, the fluid status and the blood pressure. We expect in the early stages, post-menopause, to have higher blood pressures, higher heart rates, among other things, flushing and so on. But over time, this comes back to it normalizes.
Okay. A question on GLP-1s, because why not? Everyone's asking questions on the GLP-1 medications and how they affect or even improve blood pressure, add on to the medications and statins.
This is very clear evidence now that shows that one of the major risk factors for hypertension is obesity. BMI and distribution of fat, which is abnormal. BMI above the 25 and the higher the worse. So to the extent that GLP-1 agonists, which nowadays might also come into pills, reduce obesity, they protect from hypertension standpoint. And that's why they're very beneficial. Plus, GLP-1 agonists also reduce the LDL cholesterol, the bad cholesterol, by about 20%. So we lose weight, we reduce the inflammation in our body, because having extra weight is like a bomb that you carry. And at the same time, bonus, you reduce your hypertension, you run lower blood pressures, you reduce by up to 20% your bad cholesterol, and you offer substantial risk reduction, cardiovascular risk reduction to your body. And GLP-1 agonists are pretty safe medications, injectable pills. For those who are needed, should be considered.
Yeah. Let's talk a bit of a maybe non-prescription, quote unquote, natural ways that people can help themselves. I know Dr. Hurtado Rendón, you already gave us the whole punch list of the losing weight, the exercising 4 to 5 days a week, the stopping smoking and alcohol and so forth. What else can we do? Even foods? Can foods contribute in some way? Or
there's no specific studies regarding a specific. Well, we have the Mediterranean diet that can help you also to protect your heart, of course. But if we're talking about anything non-prescribed over the counter, there's no specific studies that say if you take or zinc or some type of herbs will help you to decrease the blood pressure. A lot of patients come to the clinic and they say, well, I don't want to take these pharmacal things. I prefer these natural things, and they come with a bottle. And I tell them, listen, if you believe in that, if you think that it's okay to take if someone told you that it's okay, I don't mind if you take it, but make sure you also take your blood pressure medication. Don't stop your blood pressure medications. There's no proof that all these over-the-counter super vitamins or supplementation will help you to decrease the blood pressure. So I always tell them, it's up to you if you want to take that, but do not stop your hypertension medications.
Dr. Chatzizisis, I think you saw this question coming over as well. This person says their blood pressure's under control, but they have a high calcium score of 900. And now they're asking, is it helpful to take supplements, to Dr. Hurtado Rendón's point, omega-3s, CoQ10, vitamin K? What do you say?
I would say that obviously this person needs to see a cardiologist for sure. With 900 of calcium score, which is quite high, we need to be a little more intense beyond easy medications. I believe that all these medications that you mentioned, they do not offer any major benefit. At the same time, they do not offer any harm, so neutral. But what needs to happen for sure is to see your cardiologist and consider a stress test or even catheterization, because calcium score of 900 has a high risk for big blockages in the heart arteries that need to be addressed. I would say a good cardiology visit would be the next immediate step.
Yeah, it's almost like a common thread, because a lot of these questions, here's one that says, I have a blood pressure of 135/86, medicated. I'm not overweight. I exercise daily. I try to eat healthy. What else can you do? So I find that people are sort of grappling with this. And it's almost like to say, should they just be going to a clinic such as yours with a comprehensive approach like this?
I would say the following. Simple rule. Every man above the age of 50 and woman, every man above the age of 40 years of age, and every woman above the age of 50, they should have an annual checkup visit in a program of preventive cardiology. Prevention is preferable to cure. It's better to go see your preventive cardiology program to assess your heart health, run your labs, run your cholesterol panel, discuss about your risk factors, discuss about your possible high glucose, which might not be diabetes yet, but might get there at some point. Discuss about your extra weight, discuss about your hypertension, whether it's an early or in more advanced stages, and tailor with your doctors using imaging when needed, the calcium score or plaque analysis as needed, and tailor with your doctors a holistic, comprehensive approach that takes into account all the risk factors, as we call, modification of risk factors, and reduction of your individual risk for future cardiovascular events, because every human being on this planet has individual risk, and this risk should be individualized and should be assessed on the basis of what is your need, what is your future possible risk, and how we can minimize this. And this cannot happen through Google search or through ChatGPT. It can help, but in the hands of an expert and professional in the field, the whole concept of prevention is going to be elevated to the next level. And this is going to be translated to a significant reduction of events. This is going to be translated in better and longer life for our fellow human beings.
Yeah. And I think what I've heard from both of you is that we've moved to the stage of, yes, of course, you're always going to treat, you're always going to do intervention, but we really have moved to the high level of prevention. That's what we are trying. That's what your messages are tonight, that people have to take it seriously.
Absolutely. As I said, yes, absolutely. Dr. Hurtado, every man above the age of 40 and woman above the age of 50, tomorrow morning should reach out to a preventive cardiology program that they trust. We offer this at the University of Miami. It's a very well-organized program, but even beyond that, it has to be individualized. Imaging, that was my message, plays an important role because nowadays we have technologies that can give us a direct assessment of our heart arteries, of the health of the heart arteries. And based on this imaging information, we can tailor our risk accordingly. If needed, we can intensify and start some medications. And this is going to be of huge benefit. But this cannot happen without consulting the experts and without leveraging imaging when needed.
This question that just came over is an interesting one that I did not realize was not included in the normal labs. Is the lipoprotein A important to know? It's not normally ordered with the basic lipid panel.
It's not, or maybe it was not, but in an organized, comprehensive program, it is. The cholesterol panel, the lipid panel, as we call it nowadays, is not only the traditional total cholesterol, LDL, the bad cholesterol, the HDL, the good cholesterol, and triglycerides. Now, on top of this, we have the lipoprotein B, ApoB, as we call it, and also the lipoprotein alpha, LPA. These are important, independent of LDL risk factors, which should be assessed. And unfortunately, we don't have medications nowadays for this particular agents, for LPA. We are trialing these medications now in the University of Miami as part of our academic mission, but we're hopeful that over the next 2 to 3 years, we'll be able to have these medications cleared from the FDA and helping our community. But as you say, we have lots of patients who come to us with normal or well-controlled LDL. They come with heart attacks. We don't know what's going behind. And then you run a lipid panel and you find out that the LPA is through the roof, very elevated, and that's probably the source of the problem. It's maybe hereditary or acquired, but unfortunately, it's an independent risk factor that needs attention.
Dr. Chatzizisis, you did a great job giving us an overview of where we're headed with prevention. Dr. Hurtado Rendón, if you could do the same, give us some inspirational words for people to take home tonight. You know, hundreds have tuned in tonight on a Thursday night to listen to this important message.
Yeah, absolutely. Yes. So my main message is to be proactive. Be proactive regarding your health. Be curious about your health. Know your numbers. Check your blood pressure. If you don't have high blood pressure, excellent. But you want to know, you need to know. At this date and time, it's 2026. We need to be better and more informed about what's going on with our health so we can prevent emergency room visits, prevent and also take care of our heart, take care of our brain, take care of our main organs, our kidneys. The second thing is like take hypertension seriously. Hypertension, it's a lot of people has high blood pressure. So everybody's like, oh, yeah, I also have high blood pressure. Take it seriously because high blood pressure, sustained high blood pressure will definitely send you a bill at the end of the day, at the end. If it's not this year, it's going to be the second year. If you sustain your blood pressure elevated, it's definitely going to send a bill to your body. So take it seriously and treat it. Be very judicious and compliant with your medications. And of course, lifestyle. Lifestyle always help. Yeah.
Well, as we wrap it up, we'd like to extend to our audience tonight and all those listening that you get the Heart Month special because February is the perfect time to check your calcium screening that we keep talking about. So that's the only way to detect and to measure the calcium in your artery walls. So it's only $25 during this Heart Month, but you have to take that online risk assessment to see if you qualify. So scan the QR code, which is right there in front of you on your screen, or go to the website umiamihealth.org/heart screening. It's our gift to you tonight for tuning in and being with us. And we cannot thank our experts tonight for the privilege of their time, for their brilliance to bring such critical messages to all of us. Thank you both so much for being with us tonight and to our audience.
Thank
All right.
you.
Thank you, Iliana, for being one more time such an excellent moderator. You're a superstar. Thank you so much.
Thank you. It's always an honor for me. Thank you so much. And Dr. Hurtado Rendón.
Thank you so much.
Thank you. Good night, everyone. And please stay healthy out there, okay? Happy Heart Month.